And also, I wanted to bust another myth. Water alone is not necessarily helpful with constipation. 95% of the water in our body is already absorbed in our small bowel.
Can you tell our viewers in terms of what is constipation? When should a patient be worried about?
So, because people say that, okay, is it the frequency of the bowel movements or is it the consistency of the stool?
Any women having complicated deliveries, what you say is when a baby is big and trying to take out, either they use a forceps as a device to get the baby out. So that is why constipation is very common in females.
Yeah, absolutely. My sister eats the same amount of food and I'm like 30 pounds heavier than her, and even I eat less. So for the longest time, we didn't think that that's feasible, but now we understand that it's potentially feasible.
In my opinion, Western toilet is the number one reason for increasing rate of constipation.
The modern age, we take our cell phones there, watch whatever, or text and all that. So we're not supposed to sit on the toilet as much as we sit these days. Definitely does not help with evacuation.
Hello guys, welcome to another episode of our podcast, Gut Feeling with Dr. Pal. I'm very, very excited about this episode. I have a close friend of mine who's an associate professor in UCLA, which is one of the most reputed centers here in the United States. And also, he is also a faculty member in Cedars Sinai, again, a most reputed center, especially in gastroenterology. His name is Dr. Ali Razaie, and he is the expert in irritable bowel syndrome, IBS. I'm a gastroenterologist, but I see lot of gastroenterology problem. I see IBS, fatty liver, pancreatic problem, heartburn, or difficulty in swallowing, colon cancer screening, you name it. I know I'm a jack of all trades kind of thing. And Dr. Ali is a master of a single disease, which is irritable bowel syndrome. So I'm so glad that I was able to bring this expert, and we are going to talk a lot about irritable bowel syndrome, what is constipation, what is diarrhea, what is abdominal bloating, what should one do to prevent having all these diseases, and if you have, how do we go about in diagnosing and treating? I'm excited about this episode. Of course, talking to a colleague with a fellow gastroenterologist is absolutely exciting. I'm sure this will be exciting for you as well. Let's dive deep into it. Hi, Dr. Ali.
Hi, thank you for having me, and thank you for doing all this and spreading awareness in GI disorders, which is not many people do, but it's a very noble cause that you follow.
Yes. Yeah. People find it embarrassing. I found it enjoying.
Yeah.
But anyway, so thank you for your time. Thank you for your time. In my channel, we always talk about gut bacteria. And I really underline the importance of having good gut bacteria. But being a gut bacteria specialist, expert on microbiome, expert on irritable bowel syndrome. We have been dealing with obesity pandemic mainly in India as well.
Right.
And in my channel, we've been focusing on simple preventive techniques to prevent weight gain, decrease insulin resistance. Can you explain to us, even in detail, about how gut bacteria is linked with insulin resistance and obesity?
No, absolutely. And that's a very active field of research as well. So maybe we step back a little bit to see what we're dealing with when we talk about gut bacteria, right? So we have about 1 billion bacteria sitting in our mouth per ml. Every cc of our saliva has 1 million bacteria, right? On 1 billion. And then as it goes down, it's different types of bacteria with different abundance, meaning that it's not as much. When you go into the stomach, it's less than 100 per ml all of a sudden. And then when you go to the small bowel, it's less than 1,000. And all of a sudden, in the colon is 1 trillion bacteria in our colon per ml. If you think about that, there is a gradient of almost 1 million times difference in our small bowel versus our large bowel. And all these bacteria do different things. And one of the functions that they have is the way they affect that we digest food, the way we respond to insulin, and also obesity. Now, specifically, you ask about obesity. It's interesting. Because throughout our evolution, the gut bacteria has been with us, right, since our existence, right? If you go back to the 3 domains of life, we have bacteria, we have archaea, and we have eukarya. Eukarya are us, the ones with actual cells, right? Including fungi, including other animals, including us, and then bacteria and archaea. Funny enough, we're not just eukarya, we're also have bacteria in our body. We also have archaea in our body, right? So we are a combination of all 3 domains of life, which is actually a fascinating thing if you think about it, right?
Of course.
My sister eats the same amount of food, and I'm like 30 pounds heavier than her, and even I eat less. So for the longest time, we didn't think that that's feasible, but now we understand that it's potentially feasible. That's the same amount of food that 2 people eat. They can harvest different amount of energy and calories out of it. So that's where it's coming. So it's a very active field of research.
So you did some research on eliminating the diet and then seeing whether there is increase in the obesity rates, right? Why don't you talk about that?
Yeah, so I mean, there are different types of food that have been associated with different types of gut microbiome. Interesting enough, archaea are very resilient. If you specifically want to talk about that, and then I'll get to the bacterial part. Archaea can survive on anything, meaning that even on the sloughing of our bowel, remember, the lining of our bowel renews almost every 5 days. And while those cells die and fall off and new ones grow, that fallen group of cells can be the source of food for those archaea. They can just survive on that. So it's interesting that even if you're fasting for a long period of time, if you're in ICU, you're not even being fed, right? These archaea can survive. So it's hard to just with diet eradicate or decrease their population, although it is possible. And now we can talk about a little bit the elemental diet, right? That we will talk about. So just by changing the diet here and there, archaea are not gonna change. So interesting enough, recently we did a very fascinating study with something called elemental diet in our patients. So elemental diet is actually exactly what it sounds like. Food that are just elements. Everything that we eat comes in 3 main components, right? So it's fat that breaks down into fatty acids or fat droplets in our body. Proteins that break down into amino acids after we digest it and break it down. And also carbohydrates that they break into monosaccharides and then they get absorbed. This process of breaking these big molecules that we eat is essentially digestion. We have enzymes that break it down, right? Number 1, elemental diet has no allergen. Because what are the allergens? All proteins, right? So when you break them down into amino acids, there is no antigenicity. There is no allergic reaction to this diet. And that's actually one of the ways that, for example, elemental diet for babies have a lot of allergies. This is exactly it. The problem is that infants don't care what the elemental food or the formula tastes like. Adults do. Right? So essentially no food allergies. So essentially no allergens. So you actually go into remission in terms of allergen exposure. Number 2, all the food gets absorbed at the beginning of your small bowel. Remember, our small bowel is 6 meters, right? It's not small, right? But the whole thing is used when we eat regular food. But when we have elemental diet, it gets absorbed within the first few feet, maybe 1 meter. And the rest of it gets no exposure to food.
I see.
So the bacteria and archaea that are not native go away. Why? Because they are dependent on food to survive. But our native bacteria that are only survivable just by the sloughing of the bowel, they survive. So you get essentially a factory reset of your gut microbiome, right? So you get the lack of allergenicity, you get lack of like exposure of bacteria to food, so you get a gut microbiome. And also another thing that helps is that these amino acids help with the building of epithelial cells, right? For example, glutamine is a very important amino acid that helps the epithelial cells, the lining of the bowel, to heal, right? Otherwise, you get something called leaky gut, right? So the food goes through, right? But then when there is glutamine, it heals the lining of the bowel, and that's also another advantage of the elemental diet. So I said all this because, interesting enough, we were giving people the elemental diet at exactly the same amount of calories that they need. We were not giving them less calories, right? But even though that happened, people did lose weight. And interesting enough, we didn't rely on BMI. I mean, you better than me know that BMI is not accurate, especially when you go to Asia or South Asia. It's pretty much useless, right?
Yes.
So what we did was that we did in-body testing. So in-body testing is essentially assessing
the body fat percentage.
Exactly. So we looked at the body fat percentage and also visceral fat content. And also the muscle mass. So interesting enough, muscle mass didn't drop, right? Only fat dropped.
So based on the study that you did, let's say a patient walks into your office, how do you translate that into a clinical approach?
Right. So the next step that we're doing is that, okay, what exactly did we change that it led to such dramatic preferential fat loss, right? So we will see whether it was via microbiome, because we have stool, we have urine, we have saliva, we have blood from these patients to see what exactly happened. And eventually, I think this opens another sort of potential door to help patients, whether as standalone sort of diet or even an adjunct, right? So to help patients to first of all get a reset on the gut and also lose some weight, especially when we say weight, we want to make sure that what you lose is fat and visceral fat, right? Because that's
not the muscle mass.
Exactly, and not the muscle mass, because otherwise we're not necessarily achieving a positive result, right?
Correct.
So,
Correct. So the most common cause that a patient walks into my office is constipation. Okay. Can you tell our viewers in terms of what is constipation? When should the patient be worried about?
It's actually fascinating that we don't have a perfect definition of constipation. So, because people say that, okay, is it the frequency of the bowel movements, or is it the consistency of the stool, or is it just a sensation of, okay, I can't get this stool out of me, right? And probably it's all of the above. If you look at the textbooks, they say that, well, if you have less than 3 bowel movements per week, then you're considered constipated. Correct. But there are people that come to me that regularly have 1 to 2 bowel movements a day. If they don't have bowel movement every day, they feel constipated, right? So it's also an individualized approach. So it's interesting that we say patient is constipated when they tell you they're constipated, right? So everybody is different, right? But essentially, if you want to put an exact definition on it, is that when you are having a hard time evacuating the stool. Essentially, when you're having a bowel movement, you have a sensation of incomplete evacuation. And now, on top of it, the bowel movements are infrequent. And also the consistency is very hard.
Consistency of the stool, which is very hard on the Bristol scale chart, maybe in the first 3 or so.
Right.
And then even when the stool is in the rectum, it is very difficult to evacuate.
Exactly.
It could be because of some neurological problems as well.
Yeah, exactly. So the evacuation, something we call outlet issues. This is sometimes it's because the coordination between anal sphincter and the abdominal muscles are gone. Very commonly in the setting of obstetric injuries, for example, very common in women who have had multiple babies, or if the delivery was complicated with a tear, or some forceps was used to get the baby out. So that can affect the pelvic floor.
So it's a very important point that you're mentioning that to the audience. Any women with having complicated deliveries, what you say is when a baby is big and is trying to take out, either they use a forceps as a device to get the baby out, or you do an episiotomy where you do a small cut of the muscle to get the baby out, or if it was like a long and complicated complicated deliveries.
Exactly.
So that is why constipation is very common in females.
Yeah,
Very-
absolutely. Yeah, so outlet obstruction is a very common issue. So we can diagnose that with many things. One option is to diagnose it with good old rectal examination, right? So essentially, the doctor would ask you to squeeze and then push the finger out, and they can see that the coordination is gone. There is a formal test, anorectal manometry, to see if the synergic defecation is.
So that is just for the audience, I'm explaining. Anorectal manometry is a small balloon that they insert into the rectum.
Yes.
And then they measure the pressure of the sphincter muscle.
Exactly. So it's a catheter with a balloon at the end of it, right? And this catheter has some sensors on it, and also the balloon also measures the pressure. So a catheter sits and kind of straddles the anal sphincter, and the balloon sits in the rectum. So when you squeeze, the pressure is taken. When you push, the pressure is also taken by the rectal sensors and also anal sphincter, and you can see whether there is discoordination. So the good news is that when we find this, the treatment is actually biofeedback therapy, which is when we ask our nurses or a physiotherapist to teach you how to do this. Essentially, it's you're going to gym for the pelvic floor, right? So
basically you're training this neuromuscular circuit from the abdominal muscles to the pelvic floor to the internal sphincter and the external sphincter muscle.
Exactly.
When should a patient actually get tested?
So generally, when we hear that patients saying that, hey, listen, I have a hard time evacuating, right? So I'm sitting on the toilet for a long time and I can't get the stool out, right? Or I'm sitting there, only a small pellet of stool comes out, and the rest of it, I know it's there, I can't get it out.
I've spent 1 hour of podcast on my phone already.
Yeah, exactly. Yeah, so that's.
But when that happens, the most common thing that people go to is to take a laxative.
Yeah, exactly. So that's another way. So you're right. So one way to treat this is to liquidify the stool and make it easier to get out. So despite that lack of coordination, so that works too. But so many times it's that sensation of incomplete evacuation won't go completely away if you use only laxatives, right? So that's
so
one
sense
thing
of incomplete evacuation is you have used the bathroom, but you still feel like going to the bathroom again. That sensation.
Right. I was just actually in India for a conference, and there was a fascinating research that was presented when I was in Hyderabad that I guess there is this type of specific Indian yoga that helps with the gut, right? And they use this to help with the constipation to a point that they could empty the patient for colonoscopy.
Wow.
Yeah, so that's actually fascinating to me. And again, that kind of reminded me how important coordination of abdominal muscles and pelvic floor are for us to evacuate, to a point that they presented this fascinating research that they helped patient prep for colonoscopy with yoga pre-colonoscopy. That was fascinating. And that just tells you how important.
Of course. You know, yoga itself is mind-body coordination. We call the postures in yoga is called asanas. Okay, in India, it's called asanas. And the specific pose that you're talking about is called malasana. What mala means stool.
Oh, wow.
Asana means posture. If you assume this posture, the stool evacuation will be better. That's why it's called malasana.
Okay, so that makes sense.
I actually, this is almost similar to the squatty potty concept.
Yeah.
But they just focus on the muscle. Now they focus on the brain-body connection as well.
Yeah, absolutely. I mean, glad that you brought the squatty potty. I don't know if your audience how familiar.
Please. I don't think they know.
Essentially, a squatty potty is you put like a stool underneath your feet on when you're sitting on a Western type bathroom for your knees and your hips to get flexed more, right? Kind of to sit on a Western toilet to resemble an Eastern toilet, right? Which when essentially you squat, right? Because that's the perfect position of the stool to go out in a Eastern sort of toilet. So, and also that helps with evacuation.
In my opinion, Western toilet is the number one reason for increasing rate of constipation. Do you agree?
Well, I mean, that's definitely one of the reasons. It's because, first of all, it's too comfortable. Bathrooms are not made to be comfortable. You're supposed to get done and get out, right? So you're sitting there, especially in the modern age, we take our cell phones there.
Yes.
We just watch whatever or text and all that. So we're not supposed to sit on the toilet as much as we sit these days. Definitely that does not help with evacuation.
And also the anorectal angle.
Exactly. And any rectal angle definitely is a factor. And also when you're in a squatting position, your abdominal muscles can be engaged much better than when you're sitting on a Western toilet. So you can evacuate more efficiently and you relax the anal sphincter more efficiently. Definitely it helps.
Let me ask you this. A patient comes in with constipation. We talked about all this. Okay, he said, give me a diet to cure this.
Right.
What will the first time? I usually start with fiber. And why don't you tell us what do you do in your practice and the importance of fiber?
Right. Definitely fiber is important, although fiber is helpful in many places. We'll talk about one places that it may actually make things worse. Which is not surprising, right? Because that's what we used to do and we still do, because fiber is very helpful. For example, metamucil type sort of fiber that
psyllium husk.
Yeah, psyllium husk that we use. That definitely helps with the majority of the patients. And I definitely tell the patients to take a lot of water. Fiber without water is useless. And also I wanted to bust another myth.
Yes.
That water alone is not necessarily helpful with constipation. 95% of the water in our body is already absorbed in our small bowel. Only 5% reaches the colon. So even if you have 10 liters of water, 9.5 liters of it will get absorbed in the small bowel, and you'll end up urinating more, peeing more, rather than sort of like helping with the constipation. So water is good in the setting of good amount of fiber, so it stays in the lumen. Otherwise, just water alone is not going to help you extra to help with the constipation. So that's one important point to understand.
So it's the bacteria that produces a gas called methane.
Yes,
and
exactly.
if there's a test to identify whether you're producing methane, if that is positive, then which means that you have a lot of archaea that is producing methane.
Exactly. It's just actually fascinating that methane we can't produce methane in our body. Actually, no mammal can produce methane. So all the methane that we breathe out and is found in our breath is simply produced by the methanogen or methane producing archaea in our body, right? So the problem with that methane is that it slows down the gut. There was a very fascinating study that was done by Dr. Pimentel almost 20 years ago. And they put methane gas in the intestine of dogs. And it showed that right away that methane causes spasm of the bowel.
Wow.
Because, we have these very organized movements of our gut called peristalsis that pushes things forward, right? In the setting of methane, these becomes spastic. So it's not that there's no contraction. In fact, actually, there is strong contraction, but it's not propagating. It doesn't push things forward.
I see.
That's why these patients have cramps, but also things don't move, right? So patients with excessive amount of methane get bloating, distension, constipation. And interesting enough, when you give them, even though they have constipation, you give them extra fiber, all of a sudden they get super bloated, right? Because now this archaea break down the fiber, produce more methane, right? So that's one specific type of constipation that gets worse with fiber. So you have to be careful.
I see.
That's not the case. But as you said, the good news is that this is easy. You can diagnose it with a breath test that measures the amount of methane in your breath. And if there is excessive amount, there is different ways to treat it. For example, add specific antibiotics. Usually we use poorly absorbable antibiotics like neomycin or rifaximin and all that. That can decrease the amount of this bacteria and constipation improves. Also, elemental diet that I mentioned for people who don't want to take antibiotics.
But elemental diet is not practically possible, correct?
Yeah, I mean, well, it's becoming.
It's becoming, right?
That's the beauty of it, right? Because food. This is a trick that we would have taken out like in extreme cases. Now they're palatable now, so which is actually fascinating to me.
I mean, elemental diet is again. Elemental diet is. Pure diet broken into amino acids, carbohydrates, and fatty acids without any degradation involved.
Right.
And Dr. Ali was mentioning that it was very difficult to eat before, but now it is making more palatable.
Exactly, because we just actually presented that data with elemental diet. The rate of eradication with SIBO and EMO that we had, overall rate was 73%. And the rate of eradication of SIBO with antibiotics maximum is 50%. So it actually works. I mean, if you want to compare numbers, I mean, there's no head-to-head study. But if you look at it, it's even better. It's amazing how diet
is
can revamp things.
So that brings to the point that diet is the medicine for everything. You are what you eat.
But if you look at it, it's even better. It's amazing how diet can revamp things.
So that brings to the point that diet is the medicine for everything. You are what you eat.
Exactly.
So let's say we have constipation. Yes, you focus on fiber, and there's a particular group of patients will not tolerate fiber because of archaea is digesting fiber, producing more gas, worsening bloating. What are the other things a patient should focus on improving constipation in terms of diet?
In terms of diet. So one thing that we talked about that I want not to forget is that definitely if you have an acute type of constipation that all of a sudden you refine and constipation occurred, make sure that you think about the medications that you've just started, right? I think that one thing before I get to the diet part is that so many times patient comes in and was like, oh yeah, I'm constipated. I don't know what to do and all that. I was like, have you started something? I was like, no. I was like, any injectables or anything? I was like, oh yeah, I'm on Ozempic. I'm like, well, that's it, right? So
or a migraine medication that was recently started.
Exactly. So these newer migraine medications that can help. Or like, for my joints, I'm on like this painkiller. It's like, So that's one thing to make sure that that's not the case. Most of that data is on IBS diarrhea type,
right,
and also IBS mixed type.
Right.
They don't work as well in the IBS constipation type. So that's again the important thing that we need to understand, that you need to first of all seek medical help. Number two, if you have access to a GI dietitian, get a GI dietitian sort of like help you, right? But again, the good news is that the majority of the patients, the fiber will help, extra amount of vegetables
fruits will help.
Will help.
One thing is, when you have blood in stool, please seek attention.
Exactly.
It's a red flag.
Some people just think about blood in stool as bright red blood in the stool, but when there is maroon stool and even tarry black stool, as in just like tar, when
like a black, like a hair or a tar.
Exactly. That's actually the worst type that you need to seek sort of medical help.
Attention.
Another time is that...
Or you're losing weight unintentionally.
Exactly. So if you're losing unintentionally, because that's one other thing that I always say, patients with IBS may lose weight, but if you ask them, their appetite is fine. It's just that they're avoiding some food, saying that, well, I eat everything, I get bloated and I get a change in bowel habits, so I don't eat. So that's why they're losing weight. So they're avoiding food.
The main concern is the colon cancer.
Yes.
And in your experience, you see a lot of patients with IBS. Are you seeing colon cancer in these patients as well?
So that's interesting. So we just actually published a paper that showed that IBS patients have less colon cancer than non-IBS patients. Now, exact reason is not known, Number one might be the fact that IBS patients now seek medical help. They get colonoscopy. They get a sort of like a head of a polyp if it's existing. The other one is actually goes back to gut microbiome, right? That shows that change in gut microbiome may cause some problems, may help you in a way, right? Right. So that's actually a very active field of research
That's great.
to see what is the role of gut microbiome and colon cancer specifically, which is fascinating, and that might be the cause. So I have one good news for IBS patient, I guess, that is that the chance of colon cancer is less than general population based on the current evidence we have.
Associated with constipation, the biggest problem all my patients complain is about bloating. Whatever I eat, I feel like I am 9 months pregnant right after I eat.
Right.
And most of the times in my practice, I see that they also have constipation associated as well. So abdominal bloating, is it only constipation or is that something else that's going on? Why don't you explain?
So it's multifactorial, right? So just let's separate bloating and distension. Bloating is that sensation of fullness. Distension is when you visibly see that your belly is protruding, is coming out, right? You have to open up your belt, and as you said, like you feel like you're 9 months pregnant. You see that it's getting bigger. Most commonly, it's happening after food. So we talked about that we have a lot of bacteria in our colon, right? And much less in the small bowel. Almost 1 million times bacteria in our small bowel, right? So whenever we eat, a set of waves happen in our gut, right? So if we eat, for example, a light meal to heavy meal, the food goes into the stomach enters a feeding stage, right? Feeding stage is that when the stomach starts to break down the food, like treating sort of the food and grinding it, mixing it with acid and enzymes and all. This process takes about half an hour if you have eaten very light, or all the way to 4 hours if you have eaten something fatty and a lot of protein in it, right? That mixture at the end has to be at least 1 millimeter in smaller size, and it goes to the end of the stomach and slowly gets fed into the small bowel, right? Okay. Otherwise, if it's not broken down, the pylorus, which is the connection of the stomach to the small bowel, doesn't allow, it closes off, right? The minute it's ready to be pushed into the small bowel, then the fasting phase of the small bowel starts. The most common cause of this motility remains food poisoning or infectious gastroenteritis, right?
Food poisoning.
Yes. So when you get
very common in India.
Very common everywhere now, right? Even in the US, CDC is now reporting that 270 million cases of food poisoning are every year is happening. And obviously everywhere in Asia and everywhere. So because we travel more, we are more becoming adventurous in what we eat, right? Our travel habits have changed, right? We used to travel, go to resort, eat whatever is in there. Now, when I traveled, my family was like, okay, let's go eat some street food, see what they eat. People eat here. You want to mingle with the culture, right? The culture of traveling has changed, right? So that also has increased the rate of food poisoning, right? So whenever you get infectious gastroenteritis, you have almost 11% chance of getting irritable bowel syndrome, right? 89% of the times, it gets cleared. But 11% of the times, even though that bacteria is gone, you develop symptoms.
Wow.
Right?
So it's a very important point. Right. I think 1 in 10 patients who has this food poisoning or at increased risk of developing IBS, irritable bowel syndrome.
Exactly.
I remember that Dr. Pimentel was mentioning that whenever he goes to India or any other country, his wife is from India, I think so.
Yes.
And then he goes to India frequently. And he said that whenever I go there, I take this half a tablet of rifaximin antibiotic before each and every street food.
Right.
So that he doesn't want to be there 1 in 10.
Right.
Practically, I'm not sure how possible it is.
Yeah, I don't know if it's how plausible it is, but yes, but that's one way, right? But that's definitely one. And interesting enough, we know the exact pathway how this happens, right?
I'm going to summarize what you just said. So you eat Bhel Puri is one of the most popular street food in India. Okay, I'm just giving you an example, right? So I'm eating Bhel Puri. And then maybe the Beluru was contaminated, we don't know. I get food poisoning with this bacteria called Campylobacter. Campylobacter is one of the food poisoning causing bacteria. and I have like 3 days of diarrhea.
Right.
So if it gets better after that, I go light on the diet.
Mm-hmm.
But what we are saying is 1 in 10 times, the problem doesn't stop right there.
Exactly.
3 months, 6 months later, we start having bloating, constipation, or diarrhea and abdominal pain.
Right.
And we are like, why? I didn't eat anything now. But what has happened is because of the infection 3 months ago, your body has developed antibodies to that particular bacteria. But your body thinks that because of molecular mimicry, this antibody looks like something that belongs to you and starts developing antibodies against your normal cells.
Right.
That affects the nerve supply of the small intestine so that the waves are not being formed.
Yeah, exactly.
So a person with abdominal bloating, I feel full right after eating. What will you tell them to avoid in terms of food?
Okay. So generally speaking, well, obviously helping all these medications that we talk about. But in terms of food, what we do is that we start taking out the most obvious fermentable food out there, right? So it's, remember, bacteria don't like proteins. Bacteria don't like fat. They love carbohydrates. They like sugar, right? So, I mean, a rule of thumb is that the less sugar, the better, right? But I mean, in real life, I mean, how am I supposed to avoid that, right? So the big things that we suggest to avoid, number one are artificial sugars. We tell them not to use artificial sugars because artificial sugars are made not to be absorbed by us, but bacteria love it. Sugar alcohols, right?
So you're talking about sucralose. Artificial sweetness.
Yeah, so
aspartame.
Yeah. Aspartame is actually good to that because that's a protein one. It's a dipeptide that breaks down. But sucralose, that's not a good idea. Okay. The other thing that I usually tell them to avoid are essentially lactose. See if, because dairy associated lactose is very fermentable,
milk
right?
And milk products.
So I say lactose-free milk, or you can try a non sort of lactose
non-dairy
milk. Yeah, see if that
oat
helps
milk.
You. Yeah, I know.
Oat milk.
Oat milk is
almond
good.
milk.
Almond milk and all that. I know it might not be available everywhere, but yeah, I was just in India. Had last year. I don't know. I know milk is everywhere.
Yes.
I had my Faluda there.
Faluda.
All right, yeah. So it was, yeah. So there is, especially, at least based on my limited experience, Indian desserts, there were like a lot of milk in it. Yes,
of course.
Yeah.
And that's why people actually develop bloating and diarrhea mainly after milk products.
Yeah.
How common is lactose intolerance with SIBO?
Very common.
Very common.
So, and remember, it's not necessarily because you don't have that enzyme. It's because the bacteria in the gut love lactose so much that break it down before you break it, and they produce gas. Correct. Right? So that's one of the reasons that they have lactose they can't tolerate lactose, not because the enzyme is not there. Right?
My patient tells me that I was drinking milk at my young age. I was completely okay. Now I'm 35. Now I drink milk. I'm having diarrhea. Am I allergic to milk? What will you say?
Yeah. So first of all, yes, that's a thing. So yes, adult loss of lactose tolerance, it's very common. It happens for many reasons. Number one, we talked about bacterial overgrowth. Now there is excessive amount of bacteria that is breaking down the lactose. Number two is that when you pick up that food poisoning, right? So people probably have to Google this. Inside the lining of our small bowel, it's like villi. There are these tiny
finger-like projections.
Exactly. These are finger-like projections. And the enzymes are all concentrated at the tip of the cells. It's something we call brush border, right? Interesting enough, when you get an infection, it's almost like gets harvested. They just cut the tip of these cells, so you lose that brush border, and the enzymes, for example, lactase that breaks lactose, it decreased, right? So you do get acquired lactase deficiency after an infection, and that is one of the most common causes of lactose intolerance after an infection too, and all of a sudden in adult age. Yes, because when we're stressed, right, we do different things. We eat differently. We don't work out. We don't sleep well. for example, all those three things mess up the gut, right? Mess up the gut microbiome. If I don't sleep well, of course, my gut is not going to function. Remember, those housekeeper waves only happen during fasting. If I continuously grazing throughout the day, those waves don't happen. You're suppressing them, right? So that's why people who graze throughout the day, they generally feel bloated because they're suppressing constantly the clearing waves, right?
Thank you for supporting my fasting concept.
Yeah, no, the fasting concept is, it's actually, because, okay, so now to prove your fasting concept, because we have to go back to our evolution, right? So humans were built to wake up, have a bowel movement, right? And then go hunting or do our thing and come back, eat, and then do the same thing. So we were not built to snack like constantly throughout the day. Snack is something that is no more than 100 years old, right? So our gut was built to eat, and then having those during fasting phase, having those clearing waves to get rid of all the pathogens, all the excessive amount of bacteria, and set the gut, make it healthy for the next round, right? So if you're doing grazing, which is anti-fasting, yeah, you're suppressing that sort of defense mechanism, and you're going to cause a lot of problem, and you're going to mess up your gut microbiome, and you're going to obviously that will lead to a lot of problems. So now, one of the things that I tell my patients with IBS is definitely have 8 hours of overnight not eating, no snacking in the middle of the night. Between the meals, have 5 to 6 hours of like not eating. Don't snack in between. And yeah, tea is fine, coffee is fine. If drinking water is fine, you can do
Mainly
that.
carbs.
Yeah, exactly. Mainly carbs. Exactly.
The most common thing when I'm stressed out is I overeat. What will you tell that patient?
Yeah, so that's one thing. So that again, before talking about that tells you it's probably the constant eating that is triggering all the problems, as opposed to stress itself causing all the problems, right? So that's one thing that you have to help the patient. Obviously, advising them not to do that. If you're at tertiary center like us, I'm lucky to have a GI dietitian. I send them to a GI dietitian to help them to manage that. Also, in that situation, cognitive behavioral therapy is very important.
Please explain to us what is cognitive behavioral therapy, because I want my audience to understand.
Yeah, so cognitive behavioral therapy is essentially taking a step back, say that, okay, this problem exists. Okay, instead of denying it, instead of not coping well with it, let's accept it and let's come up with behavioral patterns to deal with it, right? So essentially how to deal with it. And that includes, for example, not eating constantly, right? So I'm like, oh my God, I'm stressed. Let's have like another pint of ice cream, right? So that's not going to help. That teaches you how to deal with stress. So that's why cognitive behavioral therapy, or CBT, is not just for this. You can use it for any chronic disease, right? To teach you how to cope and deal with it, right? So that will help you, number one, to deal with it better, and also be more motivated to seek medical help to fix it. Also, get rid of the behaviors that are worsening things during the stressful times. That actually helps you significantly.
So you mentioned about sleep. How sleep is connected to gut bacteria?
Oh yeah, so it goes back actually to the housekeeper waves, right? So when we sleep, every 2 hours, 90 minutes to 2 hours, that housekeeper waves are constantly happening. So essentially, think about it that you're sleeping and you're like the car wash on your gut is happening. So constantly cleaning and pushing everything into the colon, right? And in fact, actually pushing even stool all the way to the rectum. So you wake up and then have a bowel movement and move on, right? So that's how it's we're designed to do, right? So you need an 6 to 8 hour sleep to have at least 3 to 4 cycles of housekeeper waves to get that system cleaned out and ready and primed for the day after. That's why a good sleep matters, right? That's why a lot of shift workers, including us, have a hard time when they switch around. Because that's process is affected. That's why, for example, when we're jet lagged, we get constipated sometimes. That's why we get bloated sometimes, right? Because that housekeeper waves, that sleeping cycle is messed up, right? That's one of the reasons. So sleep is very important, right?
There was a wonderful discussion. We talked about a lot. I learned a lot. I'm sure you would have learned a lot as well. Common GI diseases like constipation, IBS doesn't have to be, compromising the quality of life. There is help around. Please write down in the comment section in terms of how you feel about the episode, how common, irritable bowel syndrome and GI symptoms in you and your family members. And please also write down what are the other guests that you would want me to, invite on our podcast, because this is Gut Feeling with Dr. Pal, between me and you. Let's make the world better.